Welcome to the Medicine and Science podcast from the BMJ. I'm Kamran Abbasi, Editor-in-Chief. This week, the BMJ has an investigation into the raw deal locally employed doctors have in the UK.
Our FOI data showed that almost 9 out of 10 trusts are employing doctors using these contracts.
We also have a new review on the benefits and harms of interventions for ADHD.
We also found that one non-pharmacological intervention, so cognitive behavioral therapy, produced a medium effect size for reducing ADHD symptoms, and this was supported by moderate certainty evidence, so exactly as medication.
And finally, former CDC Commissioner Tom Frieden joins us to talk about all things public health.
And that firing was reportedly because of her refusal to rubber stamp recommendations on vaccines that are not evidence-based.
First thing on the podcast today is some new research into benefits and harms of ADHD interventions. Navjot Lada, our UK research editor, finds out more.
I'm Corentin Gosling. I'm Associate Professor of Neuropsychology in a Parisian university, and I work in a psychiatry department in a Parisian hospital.
Tell us a little bit about how you approach this.
So the goal of the study was to create the most comprehensive and reliable overview of ADHD interventions to date. So there are plenty of scientific sources about the effect of interventions, but often they are hard to read and sometimes they produce conflicting results. So our goal was really to create one authoritative resources focusing on all ADHD. But unfortunately, the methodological quality of all existing systematic reviews and meta-analysis is very variable. Not all meta-analyses, for example, reach the same conclusion on the same topic. Our team found that about 10 to 20% of published meta-analyses contain calculation error at some stages.
Can you, it's an enormous piece of work and I don't expect you to go through all the results in detail, but is there anything, what were your key takeaways from what you found?
Exactly. It is not easily to synthesize because in total we have more than 200 meta-analyses.
Right.
So there is a huge amount of data. But if I had to synthesize the results, maybe there are two main type of results. The first is that in children and adolescents, we found that several medications showed robust and consistent benefit for ADHD symptoms, but their tolerability was often lower than placebo, either statistically significant or just above statistically significant. We found that in children and adolescents, some non-pharmacological intervention appear to have large effect, but the certainty of evidence was always very low. So in children, the picture was quite clear. Several medication, high-level evidence, and non-pharmacological evidence with lower evidence. In adults, we had very interesting findings because we also found that some medication were supported by high-quality evidence, but the effect size were more mixed. While in children, some medication like methylphenidate high effect size, in adults, all the medication had medium effect sizes. And we also found that one non-pharmacological intervention, so cognitive behavioral therapy, produced a medium effect size for reducing ADHD symptoms, and this was supported by moderate certainty evidence, so exactly as medication. In some words, this validates cognitive behavioral therapy as a very solid option for adults when people do not want to take any pharmacological option.
Interesting. What about the non-medication side of things, beyond what you've just mentioned?
Okay, in adults, all the results were as exactly as in the children, when except cognitive behavioral therapy, the results were more mixed. So unfortunately, the evidence-based was much lower. For example, mindfulness was seen as a very promising option because it had very large effect size, but on both, for example, clinician and self-rated ADHD symptoms. But unfortunately, for now, the certainty of evidence was quite low.
Was there anything in the results that surprised you or stood out to you?
Because we used an umbrella review, the results were not very surprising because they were already there in the literature. So we had nothing very new coming out, but our approach enabled us to identify very important gaps in the literature.
And what are some of those gaps?
Maybe the biggest one was on the long-term data. So for decades, we know that ADHD can be a lifelong condition, yet the vast majority or the entire majority of high-quality evidence was only about a few months of treatment. We found virtually no high-quality certainty evidence for any intervention, pharmacological or not, beyond 6 months or 1 year of follow-up. So to be clear, the entire evidence-based, high-quality evidence-based about ADHD treatment so far is coming from shorter terms.
Gosh, that's quite surprising. So no longer than a year. And if you think about actually oftentimes people with ADHD are on these medications kind of long term.
I got it. And this clearly outlines a very clear research direction for future trial is to go with longer duration. Good news is that now some new study design in terms of data analysis is coming out, for example, emulated target trial. And this enables your researcher to emulate a randomized control trial from observational data. And this type of data are good to provide evidence, more naturalistic evidence about the effect of the treatment.
Yeah.
So for us, our data should mandatory be complemented by observational evidence coming from these more naturalistic studies.
Mm-hmm. How should umbrella reviews, I mean, this type of methodology that's providing a bird's eye view, it's a hard balance, isn't it, between you want the highest quality information, which is often, trial data, but as more of these trial emulations emerge and, these gaps that are attempting to being filled by observational data, how does one get a complete picture of the evidence base? Because it's quite difficult, isn't it, to sort of marry up those kind of quality issues with the completeness.
Yeah, you are entirely right. And the issue is that because the more naturalistic analysis, like emulated trial, etc., are way more recent. And then the consequences is that there is almost no meta-analysis in the field of psychiatry about the effects found in this emulated trial. So when you go with umbrella reviews, basically you only have randomized control trial. Because only meta-analysis have almost only focused on randomized control trial. This is why we add this restriction as an inclusion criteria. We focused only on meta-analysis of randomized control trial. But in the next few years, we aim to start doing meta-analysis and synthesizing meta-analysis of non-randomized control trial. There were a few published already in the literature, but they are very, very few. And we hope that this will emerge in the coming years.
Interesting. And so what is your hope for how the impact that your research will have and how it might be used going forward?
So we have one very clear hope with that work is to facilitate the use of shared decision making. So since the 80s, all recommendations have emphasized the importance of involving patients in their treatment decision. But so far in clinical practice, it is very difficult for clinicians to present complex scientific data to their patients in a way that helps them make an informed decision. So basically, if you want to present scientific data to your patient, you have to present them meta-analysis. There are dozens. Sometimes they have conflicting data. It's very difficult. So our goal was to provide a convenient access to the scientific data so that clinicians and patients can have informed decision about their treatments in combination, for example, with clinical guidelines. So for you in UK, the goal is to have, for example, our work the NICE guideline. And of course, the NICE guideline cannot map all treatments, all outcomes, all time points. So you can just pick and choose what you need from our platform to discuss the entire evidence base.
Can you tell us a little bit more about the platform?
Yeah, so the platform is really in French, we call it the pierre angulaire. So the key milestone of this work was to create one website that is entirely free, where anyone can access and find in a convenient way the results we generated during the umbrella review. So it's a totally free, open access website where anyone, patient, family, doctor, can visualize our results. And we have provided a system where people can filter all the results we generated using, for example, filters like by age, by treatment type, outcome, and time points.
And that article, Benefits and Harms of ADHD Interventions, is available, as usual, on bmj.com. The BMJ has been looking into how the fate of locally employed doctors has become a gig economy in the NHS. We recently published an investigation on this subject. Rebecca Coombes, our head of journalism, is here to talk about that. Bex, just explain who are locally employed doctors and why are they different from the majority of doctors employed by the NHS?
Yeah, I mean, this is a part of the NHS medical workforce that the NHS doesn't talk about that much. And in fact, this investigation took us over 18 months because there's such a hidden nature to this issue. So these are doctors who are not trainees, they're not consultants, they're not on national contracts. They are on terms that are set by individual trusts. And our FOI data showed that almost 9 out of 10 trusts are employing doctors using these contracts. I think the median number was 55 doctors per trust. We identified about 18,000 doctors across the UK, but the GMC's own workforce data, which will be much more comprehensive, they say this group is growing faster than any other in the medical workforce in the UK, and its records chart a very sharp rise in locally employed doctors since 2019. Driven especially by international medical graduates. Around 2/3 of locally employed doctors are from an ethnic minority background.
Why do we think that's happening, though? Why not employ doctors on NHS contracts? Why these locally employed doctors on local contracts?
Well, they're very useful doctors to have. I mean, they are cheaper.
Yeah.
There are almost no national rules about what these jobs should look like. Obviously, the big problem is it leads to insecurity, no progression, no safeguards. They are very useful for sort of plugging in to rota gaps in an organisation. I mean, we spoke to Partha Carr, who was at the Royal College of Physicians and wrote a big report for them about this issue last year. He calls it a sort of two-tier system within the NHS. He calls them a shadow workforce.
Well, that's pretty shocking. That we're treating them less well and people don't really know about it.
No, and I think there's also patient safety concerns. I mean, this isn't just about fairness to doctors. I mean, it has real implications for patient safety. You know, some LEDs work long, unsafe hours without the right to exception report because their contracts sort of predate the 2016 safeguards.
Yeah.
Others work with minimal consultant supervision.
Yeah.
While covering high-risk services. And many do not receive mandatory teaching or appraisals.
Yeah.
I mean, several LEDs told us, and we interviewed at least half a dozen, they told us they felt pressurised to fill rota gaps with little oversight and no way of challenging unsafe work. And there's a real power imbalance here as well. Many LEDs depend on their employer for visa sponsorship. And that leaves them little room to challenge unfair treatment.
It seems an utter failure of workforce planning when we've got such a rapid growth in this group of doctors who are being employed in a way that's suboptimal for them, but also isn't best for their training and their development, which means it isn't best for patients, as you've just described. At the same time, we have doctors in the UK struggling to find training places and, unfortunately, increasing numbers who are unemployed.
Exactly. I know very few people are happy about this. The Royal College of Physicians, the BMA, the GMC, the SAS Collective all say the same thing. There must be a national framework, real supervision, and an automatic movement to SAS contracts after 2 years.
Yeah.
And, I think we saw the GMC annual workforce out last week showing there's a worrying exodus of international medical graduates from the UK. Yeah. They warn that there's a hardening of anti-immigrant rhetoric in society, and that could drive more foreign doctors away from a less welcoming UK. Today's figures show that there's a sharp fall in net migration, and that's largely driven by fewer non-EU nationals coming to the UK to work and study. And notwithstanding immigration being a big issue for the public, this trend creates serious challenges for public services such as the NHS. You've got 1 in 5 NHS worker in England has a non-British nationality.
Okay.
And Matthew Taylor of the NHS Confederation saying today, we greatly value our international workforce. Where would we be without them?
So he's seeing a workforce crisis on top of the fact that there are unemployed doctors and doctors who can't get into training.
Yeah.
There's an immediate crisis. How do you fill these particular positions?
Yeah, I think the story that comes out of our investigation, which has had a lot of reaction online from our readers, there's a lot of people seeing themselves in this story or seeing colleagues they know in this story.
Yeah.
And actually the heartbreaking thing is that, when the journalists who were conducting this investigation were doing the case studies, they felt that there was almost a sort of resigned acceptance and almost it was up to, sometimes it was colleagues saying, listen, mate, you're underpaid and you're overworked.
You mean they didn't realise?
Yeah, absolutely.
They're essentially being exploited.
Absolutely, yeah. So the story of this is that we're not valuing these highly skilled international medical graduates. And we're not treating them equally to those who are trained in the UK.
But they're not just internationally trained qualified medical graduates. It's also locally trained, UK trained doctors. Yeah. Many of whom are from ethnic minorities.
Absolutely.
But not exclusively.
Yeah.
As a group, they're getting a raw deal.
Yeah.
And I think somebody described it as working in the gig economy. Is that right?
Exactly. They said it describes their experience of working in the NHS as behaving like a gig economy employer, which means you're on very short-term contracts with no security.
Yeah.
And we found people who were on contracts like this for 17 years. Bear in mind that the recommendation is that no doctor should be on this for more than 2 years.
Yeah, it sounds like an absolute mess. So what are people calling for? What action are we seeking as a result of this?
Well, the Department of Health has said the treatment of locally employed doctors is completely unexceptional, by the way. They agree, but there's still no time frame for reform. And there's a very clear call for change that there should be a national framework. There should be real supervision and an automatic movement to SAS status.
What about contracts? They should be more secure.
BMA says that local employed contracts should always mirror the 2016 contract. And they've got quite a helpful tool online that people in locally employed jobs can use in terms of negotiation.
So the organisations that might potentially solve some of this, government, the trust themselves that employ these doctors, the GMC, is any of those organisations taking responsibility?
Not really. NHS employers say that locally employed doctors' roles should be equitable, but they do stop short of mandating changes. They do see a role for them, and as we know, they can be quite useful short-term staging post.
Yeah.
Before you go on your onward training journey, that's quite a common use these days. But this is completely different.
Yeah. So you completely get your workforce planning wrong. You have doctors who are unemployed, who can't get onto training positions, And there are certain positions you fill with international graduates or locally UK trained doctors who don't want to be on a training pathway necessarily. But you give those doctors a raw deal. They're working in the gig economy, which seems pretty shocking, considering the training and the undergraduate and postgraduate training those people have gone through, and the responsibility they carry for improving patient care. And now many of them are leaving.
And this is not a fringe issue. This is nearly 40,000 people within the NHS workforce.
Yeah.
Yeah. Why don't we hear more about it?
Yeah. Well, I think we probably are going to, aren't we?
I hope so. So.
Yeah. Well, more about the problem rather than the solution.
Yeah. I mean, I think we can hear from some of the testimonies from some of these locally employed doctors about how they've been treated, and to protect their identities, we've transcribed those doctors' words and have sort of voiced them. So I think first we can hear from a doctor working in Yorkshire, and they recount the differences between their experiences and the trainees on the ward alongside them.
So I started in August 2023. They put me down as I started as F1, which cannot be the case, because F1 usually don't have full license to practice, and I had got full license to practice. So after a year and a half of struggle, they promoted me to F2, then BMA got involved, and they had to back pay me for that whole year which I worked as F1. So I was put as F2, but then I had worked a total of 2 years, so I requested them to promote me as CT1. So first, they were a bit reluctant, because they didn't have any posts for CT, but as soon as someone went less than full time, so they put me to share the rota with that person. So I got promoted as CT level as well, but some of my colleagues are still as F2. If you are F2 or your CT rank, you don't have any training opportunities or anything. You are just there for service provision. You are thrown into one of the worst wards in the hospital. So one thing is that many of our trust grades have not had appraisals for the last 2 years. The trainees do get their appraisals. They have their CPS and everything. We have not had our appraisals for almost more than 2 years. We don't have teaching opportunities. Yeah, there's a lot of difference between the trainees and us. I understand that we are here for service provisions, but at least there should be a certain bar for us as well, for us to progress in our career. We can't be stuck like this as frustrated we are not given opportunities.
And secondly, there's a senior doctor in the East of England region, and she thinks she's losing about 25,000 a year.
Gosh. Yeah. What? So explain that.
So because she is not in a training post, because she's in a kind of, just repeating the same year over and over again, if you like, even though she's a senior doctor, she isn't getting that progression in the pay scale.
So she'd been in an equivalent post, but a training post.
Yeah.
By this stage of her career, she would be receiving £25,000 more in pay. That's right.
And she says that she's in a surgical specialty. She's completed 6 years of training. She had to leave because she had health problems, and returning has just been impossible. She didn't even realise she was on a trust register contract to begin with. And there have been ongoing clerical errors, repeated changes to staff management, constant changes of the goalposts. She just says, at no point was I given the information to make a sensible decision.
Okay, let's hear what she has to say.
It's down to money, isn't it? It's always down to money. And I wasn't in a physical position to leave the trust. And to be honest, I was very happy in the trust otherwise. Like patients, doctors, the service we provide, the care I'm giving. I've got that. I've got that balance, right? I've got that work-life balance just where I need it, for the kids and for my health. But I'm broke because of it. I'm in my mid-40s, and I was saying to my husband, I've never been more broke in my life than I am now, compared to 15 years ago when I was an ST trainee.
So Bex, where can people read about locally employed doctors and your investigation?
bmj.com, the investigations page there, it's there. And also you'll see it on our social media pages.
Finally, Mankeet Louis, our international news and features editor, talks to Tom Frieden about all things public health at a time when public health is under attack.
I'm Dr. Tom Frieden. I'm author of The Formula for Better Health, How to Save Millions of Lives, including your own. I'm also president and CEO of Resolve to Save Lives. I'm also former director of the U.S. Centers for Disease Control and Prevention and New York City Health Commissioner.
You argue in your book that we already know how to prevent most premature deaths, but we routinely fail to act. What, in your view, is genuinely new in this book compared with earlier calls for prevention? And why did you feel the need to write this book now rather than 5 or 10 years ago?
I feel that this book is necessary because there is this enormous gap between the illness, disability, injury, and death that we can prevent with our current tools and what we actually do. And what I hope the book provides is a new approach, a new way of thinking and working about this. It's a proven approach, and it starts with seeing the invisible. Seeing the invisible is the superpower of public health. And, Mankeet, really interestingly, this was first discovered in London in 1662 by John Grant. Now, many people know that this is, a classic text. I went back and read it for the first time for the research for this book, and it's really quite fascinating. This is the first ever analysis of rates and proportions and trends, the first real epidemiology. It's the birth of epidemiology, and it's quite brilliant. He, for the first time, analyzed things like maternal mortality rate, infant mortality rate. He showed emerging infectious diseases. He discussed the impact of different types of diseases on the economy, and he suggested a summary indicator of how healthy a community is, the proportion of people who survive to age 70. And he said, if any community has a higher proportion than we, they're healthier than we are. It's a great thing. And if you go back to Sir Richard Dole, he talked about death over 70 is inevitable, but deaths under 70 are not. And that core focus, see the invisible, see the microbes, the toxins, the trends that are harming people, and also see the technically rigorous process to confronting those threats. That's the first part of the formula. And that requires everyone. It requires public health. It requires doctors and the medical profession. It requires academic universities to see the path to progress, but also to see why we don't act. This is another really important aspect of seeing the invisible, because for all too long, we as individuals and public health as a field have been like Cassandra, the priestess from Greek mythology. She could see the future, but she was cursed. Nobody believed her warnings. So the tragedies that she foresaw came to pass. And again, in the research for this book, I looked into why does the Cassandra curse exist? And I go through 6 different drivers of the curse in the book, but one of them is particularly important, and it comes from another British thinker, Geoffrey Rose, brilliant and profound thinker, who coined the term the prevention paradox. What it means is that the people who will benefit may not recognize that they are benefiting, but the people who have to pay the price, whether it's the tobacco industry or junk food industry or the coal industry, they are quite concentrated on stopping the actions that will promote the public good.
I want to follow up about on 2 points really, but I want to follow up first about the seeing point. I mean, a big part of the seeing is what do we measure, whether it's air pollution or ultra processed foods or whatever. If you were running a typical health system serving a few million people, what are the first three things that you would measure properly? And what are the things that we currently measure a lot of that you think we pay a bit too much attention to?
So I would measure, if I were just given 3 things, I would look at mortality, the deaths and causes and preventability of deaths. And I would consider every under 70 death as a failure of the system. Now, some of them are truly not preventable with current means. pancreatic cancer and things like that. But many of them are quite preventable. And I would use each of those preventable events to try to improve the system. Second, I would measure the smoking rate, because smoking remains the leading preventable cause of death. And third, I would measure, much better than we do now, the hypertension control rate, because high blood pressure is the leading underlying cause of death, and systems do really poorly at attacking it. And this is one thing that my organization, Resolve to Save Lives, works on with more than 40 countries. If I had a fourth, I would measure primary health care. What is the access to, acceptability of, and impact of primary health care? And you could do that partly by looking at hypertension control.
I mean, the last one's definitely music to our readers' ears for sure. There's a lot of talk about primary healthcare every week in the BMJ. In terms of, I mean, you mentioned smoking rates, for example. I mean, one thing that strikes me about metrics like that is that do you think it's the case that we're already measuring a lot of data quite diligently, but are we not really doing enough with the data that we have here, or are people kind of ignoring it willingly out of that, or because of political kind of influences? What are your thoughts on that?
So this gets to the second aspect of the formula. The formula, again, is see, believe, create. Believe means, first, believing that what may seem inevitable is not, to shatter that illusion of inevitability. And you do that in at least three ways. The first is by documenting and reminding people of past progress. Now, often in public health, we're really reluctant to do that, because we feel like, oh, if we say there's been progress, people will think we've done enough. I think the opposite. I think that past progress should give us the confidence that we should be able to do more. But there's another thing that's really important in strengthening belief in the possibility of progress, and that's optimism. Optimism is a force multiplier. Optimism is enormously important, because without optimism, it's very hard for people to marshal the efforts, because all health progress does require some degree of struggle. And if you don't believe you have a good chance of succeeding, you're not likely to undertake the effort needed to succeed.
And I mean, that takes us to today, of course. You've written recently that the US is dismantling its own health infrastructure and retreating from global health leadership. From your vantage point, how has the current administration's approach to certainly your former organization, the CDC, and HHS as a whole, with its budget cuts and restructuring and layoffs and withdrawal from the WHO, in fact, how is it changing the United States' capacity to detect and respond to outbreaks?
Well, what we're seeing is unprecedented. There has never been a CDC director fired by the Secretary of Health and Human Services. And this is someone who was hired by that same individual less than a month earlier. And that firing was reportedly because of her refusal to rubber stamp recommendations on vaccines that are not evidence-based. We have seen quite a few political appointees take over the CDC. We've seen more than a quarter of the leaders and the staff of the organization either fired or forced to resign. We've seen half of the CDC programs or centers essentially stopped or disbanded. This is really, really damaging and dangerous. We've also seen the US abruptly stop a lot of global health programs, ranging from the closure of USAID to the pullout from the World Health Organization. And that effort included, for example, half of the World Health Organization's immunization staff who were seconded from the CDC, having to leave from one day to the next. Some of the approaches, some of the measures have an important kernel of truth, that countries should be in control of their own health, that countries need to take over the systems, that some of the systems were built in ways that were not likely to be able to be sustained effectively. But making these changes very rapidly, without planning, without a clear way forward, is resulting in a lot of disruption to life-saving systems.
I mean, there's been a lot of talk about in the media recently about whether the US is able to get as much surveillance data for monitoring outbreaks that could affect it, whether it's mpox or COVID or anything like that. I mean, do you see anything on the domestic front that is resulting from this kind of the clashing in, I'm going to say international ties, because of course it's not just on the healthcare space, it's tariffs and everything else, of course, as well. Is there anything that worries you from what you've seen?
Well, first off, the World Health Organization, which, like any organization, isn't perfect. The World Health Organization is essential for tracking of health threats. So by all means, let's figure out how to make it better, quicker, more effective, more focused. But without that partnership with the World Health Organization, we really lose the ability to track everything from influenza to toxins around the world. One of the things that my organization, Resolve to Save Lives, has advanced is a 717 target, that every health threat should be found within 7 days, reported to public health within 1 day, and all essential control measures in place within 7 days. That approach has been adopted by the World Health Organization, by the Global Fund, by the Pandemic Fund, by the World Bank, and most importantly, by 50 or more countries around the world that are using it to find threats faster and stop them sooner. And that kind of approach is part of the create part of See, Believe, Create. Because to create a healthier future, we need to be able to have clear outcomes that we use. And the importance of that metric is not as a way of saying, oh, you failed, but of using every outbreak as a learning experience so that we do better next time around.
One thing that strikes me in what you just said is that trust is a major part of this, and that was something else that I wanted to ask you about too, because it's obviously a big part of getting the public to trust us. It's obviously a big part of keeping clinicians on board in terms of what the wider framework of the public health system and the health system as a whole is doing. How do we build or rebuild public trust at a time when there is a lot of clashes between public policy, between politicians, between experts, between agencies even?
Well, first off, I do think that doctors, especially but not only primary care doctors, can play a really important role in rebuilding trust, in interpreting for patients what the data actually shows and what it means for them in their life. Trust isn't going to be rebuilt quickly. Communication is going to be enormously important, and delivering on things that matter to people is going to be really important. So I don't think there's a quick and easy answer to that. The misinformation and disinformation ecosystem moves very quickly. It's driven by economic interests that are important to reveal and counteract. I think we're sometimes bringing a knife to a gunfight when it comes to the social media world, and we need to up our game in providing fact-based, non-conflict of interest information. One of the things that I outline in the book is that we need to be clearer on our level of certainty with the scientific findings and on how important they are. So I outline for personal health and wellness, what do we know for sure will help you live a longer and healthier life? And how much will each of those things help you? And I come down to 6 things that really make a lot more difference than everything else for healthy longevity. Blood pressure, ideally to less than 120/80. Lipids, ideally with an LDL and an ApoB, less than 70. Third is physical activity. Physical activity actually is better for you than any single pill. And it doesn't have to cost anything. So that's the third. Fourth, and underemphasized, is enough sleep. Fifth is avoiding toxins, making sure that we reduce smoking and alcohol, and addressing PM 2.5 and potentially the newer toxins, endocrine disruptors, nanoparticles, things that disrupt our microbiome. And finally, and perhaps most controversially, healthy nutrition. So when you cut through all of the fog and the grifting and the misinformation and the sloppy thinking, They're really just a few things that make a big difference. There's a longer list of things that can prevent dementia and disability that are really important. And I review all of those in the book as well. I tried to bring epidemiologic reasoning and data into the personal health and wellness space to cut through the misinformation and the sloppy thinking that's out there.
That's it for this episode of the Medicine and Science podcast from the BMJ. We'll be back next time with an in-depth look at AI in the consultation room. AI is one of the legs of the three-legged stool of clinical care. Make sure you're subscribed so you don't miss that episode or any other episode. Until then, I'm Cameron Abbasi. Thanks for listening.